Psychosocial professionals sometimes express reluctance to involve themselves in medication-related issues because they feel rightly that they lack expertise in medications. This module is intended to acquaint you with both therapeutic, but especially adverse effects commonly associated with some of the most popular types of psychiatric medications.
Stimulants are the most prescribed psychiatric drugs to children in the United States and around the world. Their well-known uses as performance-enhancing agents complicates the evaluation of these substances as treatments. Despite the enormous uses of stimulants, the evidence for long-term effects is consistently unimpressive. The evidence of long-term impact on academic achievement and interpersonal relationships confirms this. These data bear on the controversy over whether stimulant adverse effects are misrecognized as bipolar disorder and schizophrenia. Of course, the treatment implications are profound. Antidepressants are a group of extremely different chemicals, prescribed across a broad range of conditions. Their effects vary widely across drugs and within users. For instance, some people might experience a particular antidepressant as stimulating, and others might experience the same drug as sedating. Overall, what they do to patients is poorly studied and understood. Over the last 20 years, much attention has been paid to determining the true effectiveness of antidepressants. Overall, treating people with antidepressants elicits only a slightly better response than treating them with placebo. Many observers consider this difference too small to be important. The large variety and number of adverse effects of antidepressants raises concerns regarding how these effects are monitored in everyday practice. Would behavioral activation be seen as anxiety or bipolar disorder and be so diagnosed and medicated? Since the FDA warning, many studies have examined the link between antidepressant use and suicide at a population level. The evidence remains mixed. The withdrawal effects of antidepressants have become quite discussed since many users started reporting them in the late 1990s. Although they are seen with every class of psychotropic drugs, withdrawal effects of antidepressants are especially diverse, affecting most biological systems. Even severe withdrawal reactions are not uncommon. Conventional wisdom about medications like stimulants and antidepressants holds them as tools that improve quality of life, allowing patients to function better than other interventions. However, evidence of this in the well-conducted studies is very difficult to find. We see evidence of drug activity in the short term, but it's hard to tell that it's a benefit when you consider the negative, medium-term and longer-term outcomes on children's functioning. As one example, in the large MTA federal study of Ritalin, methylphenidate, being prescribed as stimulant was not a marker for recovery, but of long-term deterioration. This appears to be the case for adults as well, with all the classes of medication that have been studied carefully over longer-term periods.
David, what do you think the average person working in mental health would make of these conclusions? Do you think they would be surprised?
I think many people might be surprised, many others might not. Many people might think that drugs with objectively assessed unimpressive or negative outcomes just couldn't survive clinical trials and FDA approval. But the real astonishing fact is that virtually no institution in the United States is responsibly investigating this issue of the lack of effectiveness and the worrying long-term effects of the psychiatric drugs. As a result, we keep repeating the same cycles. Every 20, 30 years, we realize that this or that drug class, like the barbiturates, then the benzodiazepines after them, the stimulants, the antidepressants, the antipsychotics, today the mood stabilizers, somehow that drug class has been largely oversold to the public and to professionals. Yet, when we realize that, there's rarely a proper accounting, as I think should occur after every public health failure. It's something like a collective amnesia, reinforced by the silence of most professionals, many of whom know better, and their representative bodies.
Jeff, what about you? Do you think practitioners would be surprised by this?
I think that many people will be very surprised to see some of this information. For example, a governing assumption in the mental health system is that the SSRI antidepressants are highly effective. But a 10% difference between placebo and SSRI isn't very big. It's not what we call clinically significant when compared to a sugar pill, and even less so when compared to active interventions such as cognitive behavioral psychotherapy. Shannon, what do you think the implications of this are for psychosocial professionals working with children?
If we recognize that harms are underestimated and benefits overestimated, then as professionals, we need to proactively monitor for potential harms with the understanding that we might observe adverse effects that have not been officially recognized in clinical studies yet. And we need to be very clear about what the expected benefits of a medication are and have a plan in place to evaluate how well the medication is performing for our client.
Anticonvulsants are principally indicated to treat epilepsy and seizures. Anticonvulsants are the only class of medication discussed in this course for which there are no FDA-approved psychiatric indications for use in children. In the 1980s and 1990s, as dissatisfaction with lithium to treat bipolar disorder grew, anticonvulsants and antipsychotics largely took over. The new name of mood stabilizers dramatically helped to sell the condition of bipolar disorder among children. As a result, an exceedingly rare diagnosis for childhood became commonplace. Since the 1950s, antipsychotics were used to treat psychoses, despite high toxicity and limited effectiveness. These drugs became widely used in all types of institutions to quiet residents and inmates. Newer, more expensive, atypical antipsychotics were promoted since the 1990s as safer and more effective than the typicals. They became and remain first-line treatments. However, since 2005, multiple large-scale independent comparisons have established that atypicals are no more effective than their older cousins. Contrary to what many might think, in kids, antipsychotics are not mainly used to treat psychosis. Rather, they're given mostly for diagnoses of ADHD, bipolar disorder, or other disruptive behavior. The underlying problem being targeted in most of these cases seems to be aggression or irritability. Movement disorders were a great concern during the era of treatment with typical antipsychotics. The risk of these problems has decreased with the use of atypicals. Akathisia, however, remains prevalent. In all age groups, atypical antipsychotics increase the risk of developing diabetes and heart disease. This produces increased cost over many years for the treatment and management of new chronic conditions.
The issue of antipsychotics in children has received a lot of attention recently. Why?
If we go with the principle of first, do no harm, then the prescription of these very powerful drugs is difficult to justify. The effects of antipsychotics can certainly make a child more compliant or suppress some disruptive behaviors in the short term. But other common effects that we've described should lead to the question, are we happy with getting a short-term benefit with the risk of harm in the long term? The chronic blocking of the dopamine system, the development of metabolic disorders such as diabetes, and brain changes found with antipsychotics, all of this should really give us pause regarding these drugs in particular.
What concerns us most about the 4 classes of medication we've reviewed? Are we keeping children perpetually at risk with no prospect of improvement? Because it's so hard to answer this question, we recommend that all children receiving psychiatric medication be reassessed thoroughly and carefully. This is a conversation that you, your supervisors, and the administrators of your agency need to be having today and on a regular basis.
All of this raises profound issues concerning the goals of the larger system of care, the broader mental health system.
And well-intended helping professionals might not realize that they're participating in a system that causes harm. This is especially so because we all have clients who we've seen helped by medications, and perhaps we haven't paid attention to some of these other effects. This is not a black or white, pro-medication or anti-medication stance that we're suggesting professionals should adopt. It's about bringing attention to how and why we use medications and what benefits people, particularly children, are really gaining.
We seem to find ourselves part of a bigger machinery, a larger system that doesn't necessarily have the health and well-being of our clients in mind as its driving motive. We say the system works for the benefit of clients, but perhaps let's consider also that it may actually serve those who deliver the policies, who make the medications, and of course the schools and families who find themselves overtaxed and overwhelmed. It's much more complex than should we be for or against medications. We don't, of course, have simple answers, but we want to bring attention to a more important question of who benefits, who in the short term and in the long term truly benefits from the practice of medicating children.
What we've described here is an unflattering look at the effects of psychiatric drugs. Some people will find some of these effects helpful and useful, and some will find themselves more harmed by medications than helped by them. Psychosocial professionals should hold both possibilities for their clients, as opposed to automatically assuming that medications are universally helpful or always harmful. What's important here is that non-medical professionals elicit and validate their clients' experiences on medications, because it is truly a highly individualized and subjective experience. In another module, we'll discuss medication monitoring and offer you a simple tool to use to monitor for adverse effects that other people might miss.